Shamaki, I will give you host.
All right, okay. Shall we start then?
Okay, Bogadaya will start.
Hello. Hello, Shama. Okay. Hello, I will cordially invite Mrs. Shamalika Pereira, a senior tutor, MLT School MRI. Right?
Okay, thank you, Mr. Bogada, but I am not the senior tutor in the school, only the tutor. Thank you very much for your introduction. So, can anyone tell me whether you can see the slides?
Right.
Slides. Okay. Then, so this is the third time I am joining with you. So today my topic is actually the liver function test. So I titled it as a pathophysiology of liver because liver functions are mainly doing for find out the liver diseases. So when we think about the liver functions, there are a lot of liver functions. So as you seen in the image, detoxification, production of cholesterol, certain metabolic functions, immune reactions, the protein synthesis, degradation of bilirubin. Likewise, there are many liver functions, but we can categorize them into mainly four major liver functions like excretion or either excretion, then the synthesis. The third one is detoxification and storage. So by doing this liver function test, actually we are screening the function of these main four functions: excretion, synthesis, detoxification, and storage. So so I would like to move on to the first one. Sorry. Okay, so I would like to go one by one. The first part I select is the excretory part of the liver. So the main molecule is the bilirubin. So as you know, it's a product from our body which we need to eliminate from the body. But before that, we have to revise our memory, how it produce and how it remove from our body. So the when we think about the excretory pathway of bilirubin, actually it's a waste product produced during the degradation of globin molecule. So mainly it can happen in extravascular systems like spleen, liver, and bone marrow, or intravascular within the blood capillary. So either in these two sites, if your red cells starts degrading this hemoglobin, as a first part, heme and globin part are separated. The globin part engaged in an amino acid spool to reuse. The heme part separately break down. So from this heme breakdown, there's a ultimate product comes as a biliverdin, which is unconjugated bilirubin we need to remove from our body. But the thing is, this unconjugated bilirubin is not water soluble one. So it needs a coupled molecule like albumin to travel until the liver. So this in our circulating blood, you can have unconjugated bilirubin coupled with albumin, which is goes to liver. Then at the site of hepatocytes,
Recording in progress.
This unconjugated bilirubin starts several steps of reaction to become a conjugated bilirubin, because without conjugating, or with the conjugated means it's a soluble, it can travel through the normal water, it's a water soluble substance. So without conjugating it, we can't remove from our body. So this unconjugation, unconjugated bilirubin converted into conjugated bilirubin in the presence of UDP glucuronyl transferase enzyme in the liver hepatocytes. So finally, this bile or the conjugated bilirubin collected through a systems of capillaries known as biliary canaliculi in our liver, and it transport the bile into the gallbladder. So gallbladder is the organ where you can store the bile fluid temporarily. Digested food particles enter into the intestine, this gallbladder bile fluid will come out. Only that instance you need this bile fluid. So in small intestine, this conjugated bilirubin, it helps with the fat soluble and fat absorption. This bile fluid is important. So ultimately, this conjugated bilirubin converted into the urobilinogen inside the small intestine because of the commensal bacteria in our gut. So this stercobilinogen, it passes with your stool, and once it exposed to the air, it converted into stercobilin, which is gives that characteristic color for your stool, yellowish color. And the rest of urobilinogen, small amount of urobilinogen will repass with your system. That means from the small intestine, there's a blood portal vein is coming, which is collected all the digested food particles. Digested food particles means what are the nutrients absorbed. So with this portal vein blood, this urobilinogen re-travels in your body. So that urobilinogen can filtered through your kidney. So ultimately in your urine, normally you can have this urobilinogen. So that is the way of excreting this bilirubin byproduct from our body through the liver. So let's move to the next slide. So now you can know at what time your blood can appear with the bilirubin, right? So in your blood, there can be unconjugated bilirubin, conjugated bilirubin. In certain instances, I will explain you later, and the urobilinogen level. So this type of bilirubin in your blood can be divided into three groups: direct bilirubin, indirect bilirubin, and total. So the direct bilirubin means what is the total amount of conjugated bilirubin. So conjugated bilirubin means it's a water soluble. Indirect bilirubin means unconjugated bilirubin, which is not water soluble. So it needs a couple with albumin molecule. So altogether, this indirect and direct bilirubin termed as total bilirubin in your blood. So when you are doing the liver function test or the LFT test, you will include these three parameters in your reports. So, but the with these parameters, you can have different functions in your body. So some fractions like indirect bilirubin indicates not only the liver pathogen, it indicates the disease Right. So the other term coupled with this bilirubin is jaundice. So as you know, jaundice is a physical sign, or that is the sign you can identify the presence of bilirubin, or something happened with your liver, right? So simply, it's a term by yellow discoloration of the skin, especially the mucous membrane, especially in your under eye area and mouth-like areas. Sometimes in the neonates, you can observe that through the skin, right? Through the skin means that yellowish color skin. So this can be due to the deposition of bile pigments, mainly the bilirubin 1. It is the most characteristic clinical sign of liver disease. So as I told you, once you observe a patient or the patient with this yellowishness, the first impression comes in your mind is whether this patient's bilirubin levels high or low or what, right? So, but the thing is, to observe in clinically, there should be a serum bilirubin level more reach to 34 to 51 micromoles per liter. So, unless it reaches up to 34 to 51 level, there can be minor levels of bilirubin in your blood, which is not clinically observed, right? So the important thing is this jaundice. If it is appear in your neonatal period, so just after born, the excess bilirubin is a toxic thing, and it can passes through your blood-brain barriers, brain barriers. So then it can cause permanent brain damages. So if you are not treating properly for these jaundice conditions, the baby end up with kernicterus, or sometimes these damages you can reverse by phototherapy or something else. But if it is irreversible damage, it will damage the brain severely, and especially the central nervous system. Of jaundice, there are already we have completed one classification, the bilirubin, total bilirubin, direct bilirubin, and indirect. The other classification related with this liver function is jaundice. So based on the jaundice pattern, you can observe 3 types: pre-hepatic, hepatic jaundice, and post-hepatic jaundice. So actually, pre-hepatic jaundice means jaundice is present. That means your bilirubin levels goes up, but at that time your liver is functioning normally. It's a pre area. That means before coming to the liver, there are organs involving extravascular or intravascular hemolysis, like spleen, bone marrow like things. So something happened to the breakdown of red cells. Sometimes the rate of red cells breakdown goes up. Then at that time, liver has to function more. So that type of jaundice classified under the pre-hepatic thing. And hepatic jaundice, or the hepatocellular jaundice, at that time, the main thing is your hepatocytes are damaged. Then post-hepatic jaundice, you're after the liver. So that means the previous part and the liver function is normal, but after the liver process, the excretion pathway is not normal. So those are categorized under the post-hepatic jaundice. So let's see one by one. The first thing, pre-hepatic jaundice. So hemolytic jaundice can be defined as an imbalance between the red cell breakdown and the bilirubin clearance. So that's why if you are normal daily, if you break down 100 red cells, if you have any hemolytic condition or due to any reason, if you start break down 1000 red cells per day, that means you are increasing the red cell breakdown. So if your liver can manage the increasing, it won't be visible. ඒ කියන්නේ දැන් අපි red cell damage වෙන එක compensate කරන්න පුළුවන් නම් liver එකට ඒක visibly පේන්නේ නැහැ. But I'm talking this pre-hepatic jaundice thing, which is more than that. That means liver unable to compensate the amount of red cells breakdown and amount of conjugation. That means liver receive more and more unconjugated bilirubin to conjugation process, but your liver unable to manage the balance between this. So more bilirubin is excreted into the bile. That means more and more conjugation processes happen and more conjugated bilirubin produced by your liver and it pass through with the bile. The amount of urobilinogen present in urine also get increased. Keep in mind, in prehepatic conditions, urobilinogen is a normal substance in your urine, but you can observe increased levels of urobilinogen. But you can't see urine bile negative. Sorry, urine bile is always negative because your liver is functioning properly and it converts whatever the amount you receive to the liver into the conjugated bilirubin. So that conjugated bilirubin definitely passes through your gut and no, unless your hepatocytes gets damaged, there is no releasing of this bilirubin into the circulation. So definitely in the prehepatic jaundice condition, urobilinogen get increase in your urine bile is negative, and when you estimation your blood bilirubin level, indirect bilirubin levels goes up, and your stool gets more dark color because of the increased production of strokobilin. So the examples are hemolytic anemia like G6PD deficiency, blood transfusion reactions, and malaria. So in these three cases, you can observe there is a huge damage of red cells. That means red cells are damaged in a fast, not like in a normal person. So let's move on to the hepatic jaundice conditions. So in hepatic jaundice conditions, hepatocellular jaundice occurs due to the liver cell damage. So that means your prehepatic area or the red cell breakdown is normal, and you are giving the same amount of red cells byproducts. That means the unconjugated bilirubin comes to the liver in normal pace. But the thing is, after conjugation, if your hepatocytes, that liver cells get damaged, those conjugated bilirubin are released into your blood. So these are the conditions where you can observe the damage to the hepatocyte, like hepatitis, viral infections, cancer conditions, cirrhosis, Gilbert disease, and certain chemicals like alcohol and certain drugs, acetaminophenol. Because some patients are there, they are having continuous ingestion of certain drugs. So because of that drugs, your hepatocytes can damage. So if something happened to your hepatocytes, it will damage, definitely the conjugated bilirubin will comes out to the blood. So at that time, indirect bilirubin levels go up. Also, conjugated bilirubin is not efficiently secreted to the bile and enters to the blood. Because of this hepatocyte damage, more and more conjugated bilirubin release into your blood. So from the blood, it can travel up to the kidney, and conjugated bilirubin easily filter through your in kidney and enter into the urine. So at that time, you can observe urine bile positive. So for the urine bile, you can do the Fuchs test or the 10% ferric chloride in TCA Fuchs test to detect this bile. I forgot to tell you, if you are doing urobilinogen, Ehrlich's test is the test for detecting urobilinogen level. And you can observe the same time urobilinogen levels goes up. So in this hepatic jaundice conditions, you can have increased bilirubin level. Urine bile is positive. That means in your urine sample, you can observe the conjugated bilirubin, and urine urobilinogen get increased. Not only that, because of the hepatocellular damage, you can observe increased AST and ALT liver enzymes. So you can make the summary charts for the prehepatic, hepatic, and jaundice diseases. So the post-hepatic jaundice, in this condition, your reticuloendothelial system or the prehepatic area is normal, and your liver is normally function and produce normal amount of bilirubin. But the thing is, when it try to go out from the liver, temporarily it should be goes to the gallbladder, and then when the requirements come, it should be comes to the intestine. Here in post-hepatic jaundice, if something block these transportation systems like common bile duct or the common bile duct, if it blocks due to some gallstones, sometimes because of the cancers, there's an issue of free flowing bile from the gallbladder. So at that time, this produced bile try to reflux. That means, as I told you earlier, once the conjugation is happened, this bile produced from the hepatocytes come through the biliary canaliculi. Those are small capillary systems which is excrete produced bile from the liver. So if something block due to some blockages, these bile try to reflow through this biliary canaliculi again. So at that time, you can observe the rupture of biliary canaliculi, and these bile substances comes directly into your blood. So at that time, you can observe the elevated levels of total bilirubin, direct and indirect bilirubin in your blood. You can get bile positive and urobilinogen negative, because there won't be passing of bile through your gut. So if it is passed through your gut only, you can have the urobilinogen because of the gut bacteria. Because of that post-hepatic jaundice condition, only the urine bile positive, urobilinogen negative, and you can observe the clay color stool. The same reason, bile is not coming through the intestine, and there is no bacterial action. So there is no production of stocobilinogen, and there is no color for your stools. So this post-hepatic jaundice mainly found in gallstones, cancers in gallbladders, bile duct obstructions, and sometimes because of the cancers present in head of the pancreas, it will obstruct the common bile duct. So in anatomy, that pancreas head is aligned with the closer to this gallbladder and common bile duct. So sometimes cancers in pancreas causing the obstruction. Right. So those are the conditions. Based on the jaundice conditions, you can classify the diseases. But at what time do we need to do the LFT, so the liver function test? So mainly clinicians are requested for the liver function test when they receive jaundice patients and patients with suspected cancers. Sometimes patients are excess ethanol injection, because ethanol it's harmful for your hepatocytes. Then suicidal overdoses like paracetamol or any other drugs. So as I told you in the first slide, there's an action called detoxification. Most of the toxic products, drugs, and everything is a liver pass substances. That means after digestion, the first organ is the liver to accept these things and detoxify. So in suicidal cases, we need to do the LFTs. Sepsis and very ill patients, acute abdominal pains in case of gallstones, because in gallstones or the patients with the gallbladder stones patients, you can immediately observe the jaundice or the bilirubin in your blood. But sometimes abdominal pain, so if you are suspecting with the abdominal pain, you can go with the LFTs. Then viral disease like hepatitis, diabetes due to fatty infiltration, then coagulation disorders, because certain coagulation factors are there, vitamin K dependent factors, and those are produced by the liver. So if your coagulation disorders appear, it's better to check whether the patient's liver is functioning normally or not. So I summarize these routine liver function tests like total proteins and albumin, bilirubin levels, AST, ALT, AST aspartate transaminase, SGOT, ALT alanine transaminases, SGPT, ALP alkaline phosphatase, GGT, gamma GT. So those are the routine liver function tests. But I classify into 3 groups. You can interpret the integrity of liver cells. So whether you want to know about the hepatocytes cells environment, you can have a better idea through these enzymes, AST, ALT, gamma GT, and ALP. If you want to estimate the excretory function of the liver, the best marker is bilirubin. And if you want to analyze the synthesis capacity of your liver, the total protein, albumin, globulin, those are the parameters which will indicate the synthetic function of the liver. So let's move on to the first one, bilirubin. So these are the bilirubin estimation methods. Just I listed out. The chromatography methods, thin layer, those are very old methods. The red color highlighted one, Gendrasik and Groff method. I think most of the analyzers also using this method, but nowadays most of the auto analyzers, they are using enzymatic method. So just I want to highlight the few points in this Gendrasik Groff method. So it's a couple reaction. The first thing you have to convert this in total. So Gendrasik Groff method we are using to detect total bilirubin. So total bilirubin means there's a part of conjugated bilirubin as well as the unconjugated bilirubin. The first thing you need to convert this unconjugated into conjugate by using caffeine. It's an accelerator. Then only this conjugated bilirubin react with diazotized sulfonilic acids or the diazo reagent to produce azobilirubin. So azobilirubin, which is in the first step, it's in acidic environment and it appears pink color solutions. Once you change the pH by using alkaline tartrate, it will become blue-green color, and which is a stable color. So that's you can use to measure the bilirubin level at 600 nanometer level. So at this 600 nanometer level, the interference due to hemoglobin or the spectral interference can remove, not only for the hemoglobin and keratin as well. So ascorbic acid, you need to use this ascorbic acid in direct bilirubin. So that means the measurement of direct bilirubin means you are detecting only the direct part. So you are not going to add the caffeine because you don't want to convert the unconjugate into conjugate. So that adding of caffeine is required only in total method, but in direct bilirubin method, you have to add the ascorbic acid to stop the coupling reaction and eliminate the interference by hemoglobin. So especially regarding specimen handling, so we need clear non-hemolyzed serum sample for bilirubin assay. So fasting specimens are not necessary, but it's recommended to avoid lipidemia, lipemia, and you should avoid hemolysis because it can cause falsely low bilirubin values if your samples get more hemolyzed. Lipemia can interfere with your absorbance reading. That's why we advise if you are a hyperlipidemic patient, it's better to go with the fasting specimen. So the common fact of this bilirubin estimation is bilirubin is a highly photosensitive substance. So it's not only sensitive to the light, it's also sensitive to the temperatures. So if you expose your sample to the direct sunlight, so it will reduce approximately 10% of your bilirubin within 30 minutes. So that's why when you are instructing boards, when you are receiving samples, you have to consider those things when you are receiving LFTs or individual bilirubin samples. So your sample should be protected from the at the site of collection, transportation, storage, and the analysis. If you are delaying your bilirubin analysis, you have to protect your samples away from the sunlight. So storage and analysis, separate the serum as early as possible and analyze as soon as possible. So if it is delayed, you have to store those samples, serum samples in dark conditions and at 2 to 8 degrees temperature. So that is the way of analyzing total bilirubin level and the requirement of specimen. So this is the just simple differentiation between unconjugated and conjugated bilirubin if it is interested. So unconjugated bilirubin present normally in your plasma and it's attached with your albumin molecule non-covalently. That means you can remove the albumin molecule whenever necessary. So it has high molecular weight and unable to filter through your kidney. And it's a non-polar, insoluble in plasma but the thing is it can cross your blood-brain barrier. So that is the dangerous part in neonates because this unconjugated bilirubin can go and deposit in your brain. So the conjugate bilirubin present normally in bile and conjugated with glucuronic acids. It's a small molecular weight. It can freely filter through your kidneys and you can appear as a urine bile. So polar and soluble in plasma, unable to cross the blood-brain barrier. So the next part under the routine liver function test, I would like to highlight this some points regarding the enzymes, so which will indicate the integrity of your hepatocytes. So under that, AST, ALT, aspartate transaminase and alanine transaminase. Transaminases, these are the two important enzymes. So AST is a cytoplasmic and mitochondrial enzyme. It's not found only in the liver. You can have it in heart, skeletal muscles, and red cells. So it's not a liver specific thing, but you can have an idea of the disease level in your liver based on these AST levels, right? So the 12 to 22 hours of half-life is there. And ALT, it's a cytoplasmic enzyme, right? It's specific to the liver, not like AST. ALT is specific to the liver. High amount released into blood during hepatocyte damage and cell necrosis, especially when your liver cells goes to the necrosis. So if you think the elevation of these AST and ALT, there's a difference between hepatitis and obstructive disease. So in hepatitis conditions, you can observe 10 to 100 times increasing of upper lower normal levels of AST and ALT commonly. Actually, it's 600 to 6,000 levels of ALT and 400 to 4,000 units for AST. So simply in hepatitis condition, you can observe much higher levels of AST, ALT than the obstructive disease, because in obstructive disease, your liver hepatocytes are normal. Up to some extent, it's normal. Because of the obstruction, you can have the bilirubin level. So at that time, normally less than 10 times of upper lower normal levels. So so that means when you are analyzing the reports, you can go through with these enzyme patterns, whether these are highly elevated or mildly elevated. Then you can have an idea whether this is a hepatic liver cell damage or obstructive pattern. Then the other two important enzymes are ALP and gamma GT. So actually ALP is mainly found in the biliary tract and liver epithelial cells. ALP is not an enzyme present in hepatocytes. Keep in mind that ALP present in the biliary tract epithelium and the liver, other normal capillary epitheliums, and especially osteoblast. That means in your bones, right? So ALP get elevated not only due to the liver diseases, it can increase due to bone diseases as well. And the other thing, you can have high ALP levels in pregnancy and growing childs, the young childs because of their growth. So if you consider about the biliary obstructions, you can have 3 times more than the upper lower normal range. In hepatocellular disease, it's not too much, right? In biliary obstructions, AST, ALT are not too much, but ALP is high. In hepatocellular diseases, AST and ALT are too much high, but not the ALP. The other important enzyme is gamma GT. It's predominant in hepatocytes and biliary epithelium. It's also low levels found in the kidney, pancreas, and spleen. So gamma GT also not specific for the liver. You can have many other organs where gamma GT present. And especially the gamma GT levels increase during biliary obstruction and many times found in alcohol and drug toxicity. So if you are a chronic alcohol user, your gamma GT levels normally in somewhere high levels. So apart from these AST, ALP and gamma GT enzymes, there's an important ratio between AST and ALT. So usually this ratio raised in similar degree with a ratio of 0.8. So if something happened with this AST and ALT level, it happened to both enzymes similar manner. But if you observe AST ALT ratio more than 2, that means your AST level is more high than the ALT levels because AST to ALT ratio. So you can observe this type of ratios in alcoholic hepatitis, hepatitis C with cirrhosis, liver metastasis, that means the cancer situations, and non-hepatic diseases like muscle disorders, myocardial infarction, and thyroid diseases. So those are the conditions where you can have AST-ALT ratio more than 2. Then low AST-ALT ratio you can observe in acute inflammation conditions and cholestasis, especially in extrahepatic obstruction, high ALT levels. That means it can be due to gallstones, or sometimes it can be a abnormal neoplasms. So the other important part of this routine LFT is proteins or the synthetic function. So up to now we discussed about excretory function related with the bilirubin, integrity of liver cells related with the enzymes, and the last part, the total protein. There's a synthetic function related to the protein, albumin, and things. So proteins are present in all body fluids, not only the blood. You can observe in CSF and many other fluids. So mainly it's the albumin, globulin, and fibrinogen combination. The predominant protein is albumin. So the globulin, you can have alpha-1, alpha-2, beta and gamma globulins separately, and fibrinogen, which is important in coagulation process. So the method, there are under the proteins, you can have the measurement of total protein, measurement of albumin, measurement of globulin. So the first part is method for total protein assays. There are many methods, all methods, Lowry protein assay, Kegel-Dahl methods, precipitation method. The highlighted one, biurate method, still practice in analyzers also. Dye binding technique for mainly for the albumin, and turbidity metric and nephrometric methods. So I try to discuss the biurate and dye binding methods only here. So the biurate method, the principle is based on the peptide bonds, as you can remember. So serum proteins form a violet-blue complex with copper ions in alkaline solution, and the absorbance of this complex is measured at 540 nanometer. So that means if your samples have peptide bonds, that means protein molecule. So peptide bond is a bond in between two amino acids. So that is the base of the constructing protein. So small amino acids joining together via peptide bonds to form a large protein. So this, if you have peptide bonds, it will couple with copper in alkaline pH with potassium iodide and sodium potassium tartrate. You can have violet blue complex. Then you can feed it at 540 nanometer. So when you are selecting the specimens, either you can use serum or plasma, but the preferable sample is serum, because when you are collecting serum, you are already removing the fibrinogen compared to the plasma samples. So fasting is not required, but it is recommended in lipemic patients, and you should avoid hemolysis. That is very much important, because we are taking the readings at 540, which is at 540 there's a similar peak of hemoglobin. So peptide bond එකයි copper එක එන absorbance peak එක වගේම the same absorbance peak gives to the hemoglobin. So that's why we highly recommended hemolysis-free sample for protein assays. So when you are collecting blood sample as a pre-analytical precautions, you have to avoid tourniquet application. Not only that, you have to consider about the patient's posture. So if your patient is lying down to come to the upright position, it will reduce it will increase 10 to 20% within 30 minutes. So when you are advising the people, keep those things in your mind to avoid the tourniquet and especially the patient's posture. Storage and stability, you can store the samples at +4 for 1 to 2 months, some kind of longer storage conditions. But if you can frozen the samples, but if you are frozen the samples, you should thaw the samples very much well and mix thoroughly before analysis. So this is the technique for serum albumin. So because other than the as a total protein, you can have globulins, albumins, and many things. But apart from this total protein, we highly selected albumin because that is the abundant plasma protein in humans and all contributes more than, almost 60% of total protein. And the albumin mainly synthesized by the liver. So if you want to have an idea about the liver pathology, the best marker is albumin. So there are unique features of this albumin molecule: low tryptophan content. Tryptophan is amino acids, and exist an anion at physiological pH. So that means at your blood pH 7.4 physiological pH, it acts as an anion, negative ion එකක් විදිහට තමයි තියෙන්නේ. So biological functions of albumin are maintains water balance in your serum and plasma and regulates colloidal osmotic pressure. And the other the important things are maintaining the pressures, and not only that, it as a transporter, or the albumin helps to transport many non-soluble molecules like fatty acids, calcium, bilirubin, and hormones throughout your body, because these molecules need transporter. So albumin is a good transporter for many other substances. So it serves as an endogenous source of amino acids. So it's simply simple structure in amino acids, and you can in your body albumin can used as a amino acid resource. So in albumin assay methods, precipitation techniques, tryptophan content techniques, and electrophoresis and dye binding are the most popular ones. So in dye binding, the main dye, commonly used dye is bromocresol green, but there are some analyzers, you can analyze the bromocresol purple one. So actually, it's not the formation of different complex. So albumin at low pH, so the acidic pH act as a cations. So these positively charged albumins combined with anion negatively charged dye substances. So it will shift your dye absorption peak in a different way. So that means so initially your dye has a certain amount of absorbance, but once the dye combine with this albumin molecule, that absorbance peaks get shifted. So based on that shifted amount, you can correlate with the albumin level. So you can measure the absorbance changes at 632 nanometer. So the intensity of this blue-green color directly proportional to the albumin concentration in your sample. So you can use either bromocresol green or bromocresol purple to detect the albumin levels. So serum is the preferable sample. Fasting specimen, as earlier, it's a desirable one, not a compulsory one. So better to avoid apply tourniquet in specimen collection because of this venous stasis. Albumin concentration can change. So storage, separate the serum within 2 hours, and especially you can store your samples at 2 degrees for 1 week, 20 degrees for 3 months. So to detection of serum globulin, actually there are many methods, but in routine practice, most of the time we are doing reducing the albumin level from total protein, then you can get your globulin. So under the globulin, it consists of alpha 1, alpha 2, beta and gamma fractions. So the best way to the quantification of these separated globulins is electrophoresis. So as a disease, you can observe high globulin levels in multiple myeloma, Hodgkin's lymphoma, hemolytic anemias, renal diseases, TB, macroglobulinemia, autoimmune diseases, and liver disease. So you can have many disease conditions with this altered globulin levels. So albumin to globulin ratio. So if you calculate this albumin to globulin ratio, it's useful in liver and nephrotic syndromes. So liver is the organ where producing albumin, but if you have nephrotic syndromes, that means the damages to the kidney. Kidney is the organ where you leaking the albumin. So if your nephrons are get damaged, you can reduce albumin level. So by looking at this albumin globulin level, you can have an idea whether this ratio is altered due to the liver, the synthesis part is altered, or excessively excrete in your nephrotic syndrome. So low albumin to globulin ratios are found due to the overproduction of globulin, like in multiple myeloma, underproduction of albumin, especially in cirrhosis conditions, loss of albumin from circulation due to the nephrotic diseases. So you can observe low albumin to globulin ratio. So high albumin globulin ratios are found due to the it reflects the low production of globulin. That means the leukemia and genetic diseases, at that time the globulin production is very much low. So apart from this liver function test, I need to add this serum electrophoresis too, because we discussed about the parts of protein like albumin, globulin parts. So serum protein electrophoresis mainly at 8.6. So at that point of pH, your proteins are negatively charged. So they move towards the anode at a rate of speed based on the net charge. So that means molecular size and the net charge, your protein molecules separated. So you can observe this normal pattern. Actually, I want to highlight these two terms. So this graph-like thing, albumin, alpha 1, alpha 2, beta, gamma, graph-like thing, this is the densitogram picture. So after you perform the electrophoresis, If you scan this electrophoresis strip, which is in lower through the densitometer, you can observe this densitogram. And the lower image, where you can observe positive end and negative ends and separate band pattern, that is the electrophoretograph. Not these two images are different, and two terms you need to use. So this is how the movement of protein electrophoresis and electric field. So in cathode area, you have to apply the samples, applications of proteins. Once you apply the electric field, the most negatively charged, the purple color is the molecule which is more negative charge. It travels very fast to the anode end, and then lowest the second level of negatively charged is in between that, and lastly less negative charge are remaining closer to the application point. So that is how this electrophoresis separation takes place. So this is the normal pattern. So the in each and every slide I show you the densitogram as well as the electrophoretograph. So this is the normal one. You can have 5 bands: albumin, alpha 1, alpha 2, beta, and gamma. So under these peak areas, you can calculate the amount of protein, albumin, likewise. So this is the normal pattern. Then these are the chronic inflammatory response, like autoimmune diseases, chronic liver diseases, infections, and cancers. You can observe normal low albumin levels, increasing alpha 1, alpha 2 globulins, and much more increasing of gamma globulins. So these are the chronic inflammatory response pattern. And this is the liver damage or the cirrhosis conditions. You can observe low albumin levels, low alpha 1, alpha 2, beta globulins. And the important thing is you can observe the beta gamma fusion. Gamma globulins and beta globulins are merged together. We called it as a beta gamma fusion. You can observe especially in these cirrhosis patients. So these are the next step of electrophoresis, immunofixation. So that means after you separate the total proteins through your normal electrophoresis, you can further separate these proteins to detect whether this is IgG, IgA, IgM, kappa or lambda. So that means you can further classify these globulins into further levels. Especially this immunofixation helpful to identify these multiple myeloma bands. That means whether this is a IgA, lambda, or kappa. That means you can easily classify the disease up to that level by using immunofixation electrophoresis. So those are the tests related with the liver functions test. So don't misunderstand this. Electrophoresis thing is not comes under your LFT, but I add this, then you can easily identify the what are the tests that you need to analyze in a patient with liver diseases. So these are the common liver diseases: acute or chronic hepatitis, cirrhosis, non-alcoholic fatty liver, tumors, and infiltration. So sometimes the tumor starts itself in the liver, sometimes it's an infiltration, so the metastasis of from any other place. So other than these liver function tests, this is the list of tests that useful to evaluate chronic liver diseases, like serum ammonia level, because in hepatocytes this ammonia converted into urea and excrete through your kidney. So if your liver cells get damaged, ammonia accumulated in your body. So if you are suspecting chronic liver disease, it's better to check your ammonia levels too. Then hepatitis serology in liver disease. So that means hepatitis panel. you can perform hepatitis B surface antigen, hepatitis A, C likewise. There's a panel of hepatitis testing if you're suspecting chronic liver disease due to hepatitis. Then autoantibody screening like anti-nuclear antibody ANAs, positive in autoimmune hepatitis, anti-neutrophil cytoplasmic antibody ANCAs, positive in chronic liver diseases. So the alpha-fetoprotein is the tumor marker, hepatocellular carcinoma marker commonly used. Then serum ceruloplasmin level, actually ceruloplasmin is the molecule which contains copper level. Then serum iron studies, scan reports, ultrasound scans, MRI scans, which will help to evaluate the liver conditions, and especially the histology reports. Either it can be a fine needle aspiration or biopsy. So these are the list of tests other than the liver function test you can use to evaluate the liver disease. So that is the end of my presentation. Thank you very much for the kind listening at this busy time. So if you have any questions, you can use either chat box or you can talk. මොනවා හරි ප්‍රශ්න තියෙනවා නම් අහන්න, නැත්නම් chat box එකේ දැම්මත් කමක් නැහැ. Do you have any questions? Yes, I can upload the presentation as a PDF in the evening. Within another 1 or 2 hours, within another 1 hour, I will upload the presentation to the group. Thank you. I think LFT is a routine test, which is very familiar with you. So you can go through easily with these samples and testing things. The important thing when you are selecting the samples, especially you should consider about the hemolysis, not only for the bilirubin and things, especially for the ASTs, aspartate transaminations, which is highly presented in your red cells. So hemolysis can affect on the AST levels too. And the ALP, if your samples get contaminated with EDTA, because EDTA is a substance which chelates calcium as well as the magnesium. Magnesium is important to ALP function. So if you have low ALPs, unusual low levels in ALPs, so it's better to check the magnesium levels in your LFT samples too. Other than that, the sample collection, storage, and those things are common. No questions. Okay, shall I stop then? කවුද ඉන්නේ? දිනේෂ්ද බොගඩය දින්නේ?
Right. Thank you, Shama. Your valuable support for conduct our online refreshment training. Today, another lecture, 7:30 p.m. Right? I think anemia classification topic. Right. Thank you for Shama. Right.
So thank you everyone, and thank you especially for the Mr. Bogada, Dinesh, and who are organizing this program. This is the very first time I'm talking with this much of LTs. So thank you very much for inviting me, and I think that this is my last lecture. So if you have any query regarding this biochemistry thing, please contact me. And I would like to highlight, other than this EQA, IQC, lipid, liver, and things, it's better to, if you can, better to go through with the other samples like calcium, electrolytes, especially sample collection and the problems like thing. Then you can cover up almost all the biochemistry things. Okay, thank you very much and wish you all the very best for your upcoming exam. I hope you can do your maximum and hope I will help you
Thank you, madam.
uplift your knowledge. Thank you very much.